Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome back Jonathan Bushman, family physician and health benefits advisor. Today's Kevin MD article is The 5% Problem, the Low Value of Primary Care. Jonathan, welcome back to the show.
Thank you for having me.
All right,
Appreciate
so
it.
tell us what led you to write this article and then about the article itself for those who didn't get a chance to read it.
Yeah, absolutely. So what inspired me to write this was several years ago now, it's been about 3 years ago, I was looking into getting into the benefits space really as a consultant, as a collaborator. And I had an opportunity to take a few smaller cases locally. Well, of course, that requires a license. And I've been around benefits, obviously being a family physician, we've learned coding and billing and all that stuff for so long.
Mhm.
But my first job out of high school was actually filing HCFA 1500 forms. I saw them in a neurosurgical practice. I was seeing the billed charges, the allowed charges, the paid amounts. We were auditing EOBs. And so for the long time, I've been a part of sort of that billing slash benefits side. And I've always had lots of questions around it, but I've also had the education. And when I decided to get this license, I literally logged in to the state insurance portal, scheduled a test for later that day at 5 o'clock when I finished up clinic, logged in, took my test 30 minutes later, and $38 later, I'm a licensed insurance agent.
All right.
And I did see the humor in that at the time, how simple that seemed. And over time, I'm just thinking, I keep going back to, I look over at my wall and I'm like, okay, this diploma sits here. And I'm like, you start thinking about how long it took me to get into the position of taking care of people. And I'm like, okay, 4 years of undergrad, 4 years of med school, 3 years of training. I got 11 years of my life. I sort of gave up my 20s, if you will,
Mhm.
right? I've dedicated my 20s to education and professional training. And I have about, at the time, had about $300,000 in debt to show for it in 11 years. And then as I was framing my insurance license is when it hit me. I put it up on the wall and I was like, holy crap, look at that. $38, 30 minutes versus 11 years and $300,000. And then I started thinking broader, right? Because, we've always heard primary care is, it's just not invested in like it should
Mhm.
be, right? And we look at the nearly $5 trillion healthcare system, and the estimate across the system is that primary care makes up about 4%, right? I did not know the economics getting into insurance. Okay. I don't have a large book of business. This isn't a career replacement for me. This was an add-on because the opportunity arose and I see the value in doing it. But then when I get my first commission check and it's 5% of the total premium spend, not even this claim spend, but the total premium spend, and I get 5% because I sold a product, that's kind of when it hit me. That like we've got a problem. And my post, the article, was not it was not an insult to brokers. It's not an insult to insurance agents, et cetera. Maybe an insult to the industry. Perhaps we've got it wrong where we invest our monies and how we reward those within the industry. I've had the opportunity to be a part of multiple conversations with advisors and brokers and gone to multiple conferences now, and I've gotten in the room and I'll be honest, Kevin, sometimes I'm like, I'm probably the lowest net worth person in this room.
Mm.
And they look at you and they go, "What is a physician doing here?" I'm like, "I'm I'm I'm working in the same space because I'm trying to bring that clinical eye and clinical perspective to the discussion of purchasing benefits." And that I have realized is apparently I'm a unicorn for that. Nobody sees that. Nobody sees the value in that. And that to me is kind of the problem too for us as physicians is like we're in the space all day long, but what do we know of the space?
Yeah.
Do we know how this actually functions?
Yeah, and that's like a whole field, right? Health economics isn't traditionally taught in medical school and residency, but it's such a big part of our lives, especially as outpatient physicians. Now,
Hmm.
there's still a misconception, right? Like you mentioned that story where you went into that room of insurance brokers and they were wondering what a physician was doing there, and there's still that misconception that physicians, we have the fancy cars and the yacht, and that really doesn't portray the reality of what primary care doctors are.
No, absolutely. And Kevin, I actually recently read an article about how physicians, in many cases, particularly primary care physicians, are becoming, right in the middle of the middle class anymore, where in some ways, historically, physicians were typically the upper middle class. The wages have stagnated, the burdens of the job have increased, and they found themselves in kind of, a typical middle class kind of income. And I didn't get into medicine specifically for the income, but it is kind of interesting. There's this, I think, a public perception, again, like you mentioned, the public perception is that we're very, very high income earners.
Hmm.
And it's not always the case. And again, that's not what we're in medicine for, but it is an interesting observation. In primary care, as you know, across the board, access is becoming more and more of a problem because students aren't choosing to go into primary care. There's quite a few in the profession that would look at primary care as a dying breed. I actually think the value of primary care, if people aren't recognizing it in today's world, you give this another 2, 3, 4 years, just wait.
Hmm.
When access becomes an even bigger issue, the value of primary care is actually going to go up. And there is not a replacement for what primary care does in a healthcare system. You can measure any variable, and there's nothing that makes as dramatic difference in the health of a population down to the individual level as primary care does.
In your article, just want to reiterate some of the statistics that you mentioned. Primary care accounts for 5% of healthcare spending, but handles 90% of the healthcare issues of our patients today. And then you, of course, equated that to your broker's license, which you got in 30 minutes, and you got
Hmm.
5% of the commission.
Hmm.
Now, is it simply a matter of money? If we just threw more money at primary care, do you think that would solve the problem?
I do not. However, the issue with money in primary care, I think from a recruitment slash workforce issue is a problem. So, a lot of people kind of joke if you go into primary care, you know that you love people. So one thing that we never have to question is if you went into primary care, you love people.
Mm-hmm.
Because from an economic standpoint, it doesn't look like a great decision to make when you're in medical school. If you start looking around and looking at the income levels and also the work, the burden of the work involved. So you truly have to have the right mindset, the right heart in medicine to go into primary care. But I think it's got to be more attractive. Now, you can't just throw money at it. It's more than that. So it comes down to literally what does the what does the day-to-day work look like? What's the influence that we can have with our patients on a relational level? So there's a lot more to it, but we've got to make primary care attractive again. We have to.
So, what are some of the ways that you suggest doing that? I know we've been talking about this for almost seems like decades now. Now, if you're in charge of our healthcare system, other than the money, because I've heard the same thing too. A lot of medical students who shadow primary care doctors, they see a lot of the burdens that they have to go through. How would you change the profession to make it more attractive to a new cohort of medical students?
Absolutely. Well, for one is the payment models, right? We know fee for service is broken. We just haven't found the exact replacement in across the board. Medicare's got multiple models to try. There's some definite positives coming from that, but there's not one perfect thing. But what I've found is, and this has been where in the benefit space specifically, working with employers, I'm not working as much in a government style program, but these are in many cases self-funded employers. Self-employment employers, let's talk about that for a moment. Employers really bear the weight of the entire medical system, right? The
Hmm.
taxpayer, the working class do, because for one, they're paying for their own employees' health benefits, and then, the taxes from the wages they're paying, to keep Medicare and Medicaid alive. So employers take on a big burden, but they are also nimble enough and independent enough in a lot of ways that they can look towards innovative payment models or innovative care delivery that kind of changes the conversation. And as I've recognized, it's interesting that I feel like my job as a primary care doctor has only been enhanced. I've only gotten better by learning the benefit side. And the biggest take home message for me in getting in benefits is that being a benefits advisor has taught me how to be a primary care doctor, specifically in risk management. So if you think about healthcare, you have two different highways. One's a financial risk highway and one's a clinical risk highway.
Hmm.
Well, we've been taught the clinical risk, right? That's what we understand. Now, we don't always have the data for it, but we try to get our data and we try to manage clinical risk. And whether that's, picking up on early insulin resistance and trying to help somebody change their lifestyle before they develop prediabetes and then diabetes, or if it's someone who's acutely ill, but we have the methods to intervene and manage the risk so they don't end up going on to that next level of care, ER, hospital, et cetera. And so that's what we've been taught clinically. We get that. But then getting into benefits advising, understanding health plan design, and it is like a second language. I mean, there are so many things in the insurance world that's second language. But understanding that is a financial risk. And in a health plan design, what we're doing is we're literally paving the highway for healthcare. And we're putting up guardrails and we're painting the lines and we're setting speed limits and we're doing all of those things, trying to design a safe way, a safe highway for patients to travel in.
Mm-hmm.
But guess what? The people who designed the highways and who run the highways, they don't make the cars. They don't have anything to do with the safety features in the cars, and they also don't control the drivers.
Mm-hmm.
So there's only so much they can do in risk management. Then you have all the midstream in healthcare. Those are the vehicles. And you got multiple different manufacturers and you got multiple different safety measures and multiple different price points, et cetera. But they still don't control the drivers. The drivers are the patients. And those patients, sometimes it's things they can't avoid, road hazards or weather conditions are different, et cetera. You get the analogy here is that like there are still some uncontrollable factors for the drivers on the roads. But if everyone's done their job from, as I think of it, upstream, downstream to the exam room, it really is one large conversation of risk management. And that's actually where I've kind of found my niche is really in that middle ground. Okay, now I understand clinical risk, I understand financial risk. Now I have a voice within the middle who can translate both sides. And I'm actually working along with population health vendors to do just that. Where if you have the data, you can engage the right people. And I think as you see, as kind of mentioned, the workforce issues in primary care, what I hope and also what I see is that primary care physicians, when they've been empowered with the right data and the right partners and the right payment models, and when all of those incentives can align so that the patient wins every time, it's a very, very high satisfaction job, right? You can love your job when you know that everyone upstream took care of making sure the downstream worked. And that to me is the real benefit of being in the benefits conversation.
Earlier, you said that when you were in a room with the other benefit advisors, you were kind of the unicorn because you were a physician and had that clinical expertise. Now, for other physicians who may want to get involved into the benefit space and maybe vary some of the things that they do in the primary care setting, how can they get started? What are some avenues that they can pursue?
Yeah, so I mean that's a great question, and to be fair, Kevin, there aren't really a lot of them. There's not a place for physicians to go. This isn't something that's taught at CMEs even, not let alone medical school or residency, but they don't teach this at CME. You don't hear about it at CME. If you walked into a benefits conference today as a physician, you would definitely feel lost if you didn't know the language. But there are organizations like Health Rosetta is an organization. I actually recently attended U-Powered Symposium, which is also a benefits conference. And these are benefit leaders who are thinking outside the box, innovative plan designs. They're really doing phenomenal jobs at aligning those incentives as I was saying. And getting in a room with people who know they want to translate great design into the exam room. One of the greatest things about getting into a group like a Health Rosetta or U-Powered is that you get in front of these people and you realize these advisors love people and they truly are in it for the right reasons, and it shows in everything that they do. So those are a couple different places you could explore as a clinician, but I think there's a paucity of opportunities, if you will, for physicians to truly understand benefits. Yet literally every patient we take care of in some form or fashion either got there or will not be able to get what they need, because of the way the benefit. And you know this, you've practiced clinical medicine long enough to be like, how many times you throw your hands in the air and you're just like, I don't even know. And patients will complain about their benefit or this or that. And it's like, I don't even know what drives that. So getting the education, getting kind of neck deep in it, and you start to understand the variables and why things are happening. As you know, it's really hard to solve a problem if you don't know why the problem existed in the first place. And that's really, really, really probably the most important piece of the benefits conversation is just understanding how it works.
We're talking to Jonathan Bushman, family physician and health benefits advisor. Today's Kevin MD article is The 5% Problem, the low value of primary care. Jonathan, as always, will end with take home messages they want to leave with the Kevin MD audience.
Absolutely. So, physicians listening, learn. Do everything you can to learn about benefits because when we think about the social determinants of health, we know that the economic side of someone's health is every bit as important and contributory to their health as what we're doing as primary care. So if we can advocate for them in a manner that's financial as well, I will say that that breeds even deeper trust with patients. And so that's really the call to action is do what you can to learn about benefits, learn about incentives, learn about the way that dollars flow within the healthcare system so that we can treat our patients even better.
Jonathan, thank you so much for sharing your perspective and insight. Thanks again for coming back on the show.
Thanks for having me.